I want you to just imagine for a second that you have a headache. So you go to the cabinet, you swallow a simple pill, and, well, you just wait for the pain to go away, right?
Yeah, that's the standard expectation. We just assume the drug goes in and does its job.
Right. But what's crazy is that behind the scenes, inside your body, your organs don't see relief. They actually see this foreign chemical invader.
Exactly. It's a massive, high-stakes mathematical war playing out on a cellular level.
And that invisible war is exactly what we are exploring on today's deep dive. We are digging into pharmacokinetics.
Which I know sounds like intense medical jargon.
It totally does, but it's really just the study of what the body does to a drug, like opposed to pharmacodynamics, which is, what the drug does to the body.
Right, exactly. And the framework that rules this entire field, especially in nursing and pharmacy, is an acronym. It's ADME.
ADME. So that's absorption, distribution, metabolism, and excretion.
You got it.
Mhm.
Sometimes you'll see textbooks add an L at the beginning for liberation, like how a capsule breaks apart.
Oh, right, LADM.
Yeah. But ADME is really the gold standard at the bedside. And what's fascinating here is that the core mechanical idea is just your body actively trying to move this chemical, dilute it, chemically disarm it, and just flush it out.
Okay, let's unpack this. Because to really understand how we track a drug's journey today, we kind of have to look at how doctors used to do it, right?
Yeah, yeah. Which was not great. It was pure trial and error,
Just totally guessing.
pretty much. I mean, historically, you'd administer a dose and just sort of watch the patient and hope for the best.
Wow, that's reassuring. So when did we actually start applying math to this?
So that brings us to around 1937 with a Swedish physiologist named Torsten Tierell.
Okay.
He was the first to build these coupled compartment models, basically using differential equations to track a drug.
But didn't the sources say his math was just entirely ignored?
Yeah, for like 2 decades. Because, computers didn't exist to solve his equations quickly.
Right, you're not going to sit there doing advanced calculus by hand while a patient is, crashing.
Exactly. So it was just theory until 1953 when F.H. Dust, this German physician, coined the term pharmacokinetic.
And he was the one who really pushed back on the guesswork, right?
Right. He absolutely hated the trial and error dosing. He wanted to measure the actual concentration time curve. He wanted to know exactly why a drug worked one day, but became totally toxic the next.
So to do that, early scientists essentially had to treat our really complex bodies as these idealized fluid compartments, like a couple of connected water tanks.
Yeah, that's exactly what the one-compartment model is. It's a mathematical black box.
Wait, but we still use that today, right? Like treating the body as a single tank.
We do, yeah. Like if a nursing unit is dosing vancomycin, they're often using formulas based on that one-compartment logic. It's simple, but it works for certain things.
But it's not the cutting edge anymore.
No, not at all. Modern drug development uses what's called PBPK, or physiologically based pharmacokinetic modeling.
Which sounds way more complicated.
It is. Instead of a theoretical water tank, it uses actual organ blood flows. Pharma companies run these totally in silico, like on computer simulations, before they ever test a drug on a human.
That is wild. Okay, so since the math tells us the body acts like these compartments, let's look at how a drug actually breaks into them.
Right, starting with the A in ADME, which is absorption.
And this is all about bioavailability, right?
Exactly. Bioavailability, or F in the equations, is just the fraction of the dose that actually makes it into your systemic circulation.
So if you get an IV, it's just 100%.
Right, because it goes straight into the blood. But oral drugs, they face a massive gauntlet. Stomach acid, intestinal enzymes, and then the big one, the liver.
The liver, our sources basically describe the liver as this overzealous nightclub bouncer just sitting right on the portal vein.
That is a perfect analogy, yeah, because all the blood from your gut goes to the liver first. It's the customs checkpoint.
The first pass effect.
Exactly. And the liver's job is to screen for toxins. If a drug looks suspicious, the liver just destroys it.
Which is why we have to give certain drugs in weird ways, like the nitroglycerin example from the source material.
Well, nitroglycerin is a classic example. If you swallow a nitroglycerin pill for chest pain, the liver clears so much of it that it's basically useless.
So swallowing it does nothing.
Almost nothing. That first pass effect is just too aggressive.
So that's why you have to put it under your tongue, sublingual.
Exactly. Under the tongue, the drug absorbs directly into the systemic circulation, totally bypassing that bouncer at the liver.
Okay, so that's getting in. What about the D distribution? Once it's past the bouncer, where does it go?
This is where the math gets really counterintuitive. We use a concept called volume of distribution, or V-day.
And this is the one that kind of blew my mind in the research. Because, okay, let's talk about digoxin.
Right, the heart failure medication.
Yeah, digoxin has a V-day of like 500 liters, but the human body only holds about 42 liters of water. Wait, how can a drug distribute into 500 liters of space in a human that only holds 42 liters of water?
Yeah, it sounds completely impossible. But the key is that V isn't a literal anatomical volume. It's a theoretical volume.
Okay, break that down for me.
So digoxin binds really aggressively to your muscle and fat tissues. It loves those tissues.
So it doesn't stay in the blood.
Exactly. Very little stays in the blood. So when you draw a blood sample, the concentration looks incredibly low. The math formula spits out this massive volume to explain why there's so little drug in the central plasma.
Oh, I see. It's just hiding out in the tissues.
Exactly. And clinically, this is huge. If someone has digoxin toxicity, you cannot use dialysis to save them.
Because dialysis only cleans the blood.
Right. You hook them up to a dialysis machine, but the drug isn't in the blood to begin with. It's hiding deep in the tissues. Dialysis is totally useless.
Wow. Okay, so that perfectly transitions us to the second half of ADME, the disarming and the evicting. Because if a drug is hiding deep in our tissues like that, the body has to actively chemically disable it and kick it out.
Right. And that is metabolism and excretion. So for metabolism, the liver uses this massive family of enzymes called the cytochrome P450 system.
The CYP450 enzyme.
Yeah.
Okay.
Their main job is to attach things to the drug to make it more water-soluble, so the kidneys can flush it out later.
And most drugs follow what's called first-order kinetics.
Right. First-order kinetics means a constant fraction of the drug is eliminated per unit of time.
Meaning it has a fixed half-life. Like half is gone in an hour, half of the rest in the next hour.
Exactly. It's predictable. But there's a very dangerous exception called zero-order kinetics.
Right. And here's where it gets really interesting. Because zero order is when the enzymes basically get overwhelmed, right? They get saturated.
Yes. The enzymes hit their absolute maximum working speed. So instead of clearing a fraction, they can only clear a constant amount.
Like ethanol, alcohol.
The perfect example. Your liver clears roughly 1 drink an hour, no matter what.
So if you have 5 drinks, it doesn't speed up, it just takes 5 hours.
Exactly. It just backs up in your bloodstream.
And the sources mentioned phenytoin, the seizure drug, acts this way too.
Yeah, phenytoin is notorious for this.
Because doubling a dose of phenytoin doesn't just double the level in your blood, right? It creates this disproportionate, non-linear cliff.
Exactly. The enzymes are already maxed out, so that extra drug just accumulates rapidly, and it can easily become toxic.
Which sounds terrifying for a doctor trying to figure out a dose.
It is. It takes really precise monitoring.
So after metabolism, we finally hit excretion, how it actually leaves.
Right. And the key concept here is clearance, which is the volume of blood cleared to the drug per unit time.
And this is mostly the kidneys doing the work.
Usually, yes. And to figure out kidney function, we still use the Cockcroft-Gault equation from 1976.
Which uses creatinine, right?
Right. Creatinine is a byproduct of muscle breakdown. So we measure it to estimate how well the kidneys are filtering. But that 1976 equation adjusts for age and weight, which is vital.
Vital because an elderly patient might have failing kidneys, but very little muscle mass, right?
Exactly. So their creatinine levels might look deceptively normal on a lab test. The math has to correct for that, otherwise we'd end up severely overdosing them.
Man, the math really is everywhere here. But we've established how this elegant ADME system is supposed to work. But history shows us what happens when we assume everyone's ADME system operates identically.
Yeah, and the consequences of that assumption have been catastrophic.
Which brings us to the thalidomide tragedy.
Right. In the late 50s and 60s, thalidomide was used for morning sickness, but it caused horrific birth defects.
And it was because of chirality, right? Like the drug had 2 mirror image forms.
Yeah, stereoisomers. There was a safe version that acted as a sedative, and a toxic version that caused the malformations.
But the wild part is you couldn't just isolate the safe version and give that to patients.
No, you couldn't.
Wait, so the body actually flipped it?
Yes. The physical environment of human blood plasma caused the drug to interconvert. So even if you swallowed purely the safe version, your own body would flip a portion of it into the toxic version.
That is just heartbreaking. And that's what forced the 1962 Kefauver-Harris Amendment, right?
Yes, exactly. It forced pharmaceutical companies to prove efficacy and conduct rigorous pharmacokinetic testing before approval.
But even with all that testing, we still have these massive variations today. I mean, the sources outline that terrifying 2006 case of the infant who died from morphine toxicity via breast milk.
Yeah, that is a profoundly tragic case and a perfect example of pharmacogenomics.
Right. Could you explain the role of pharmacogenomics in that case? Because the mother was just taking standard codeine, right?
Right, the normal dose. Codeine itself is actually a very weak drug. It doesn't do much for pain until your liver enzymes, specifically the CYP2D6 enzyme, convert it into morphine.
Okay, so the liver normally turns a little bit of it into morphine.
Exactly, normally just a small fraction. But this mother was what we call an ultra-rapid metabolizer.
Because of her genetics?
Yes, she had multiple genetic copies of that CYP2D6 enzyme, so her liver converted that weak codeine into a massive amount of morphine, unusually fast.
And that went straight into the breast milk.
Right, and it completely shatters the old misconception that same dose, same drug equals same outcome. Because of her genetics, it was a lethal dose. Pharmacokinetics is highly, highly personalized.
It's just wild how a tiny genetic shift completely changes the math.
Absolutely.
And sometimes it's not even genetics, it's just breakfast. I have to bring up the grapefruit accident.
Oh, David Bailey, classic.
Yes, David Bailey in 1989. He was doing a study on alcohol and a blood pressure drug, and he just used grapefruit juice to hide the taste of the alcohol.
Right, totally by accident.
And he accidentally discovered that grapefruit juice multiplies the blood levels of certain oral drugs.
It acts as a severe enzyme inhibitor. Grapefruit inhibits intestinal CYP3A4.
So it basically takes out the bouncers in the gut wall.
Exactly. So drugs that normally get heavily metabolized in the intestines suddenly just slip past unmetabolized. You get a massive spike in drug concentration in the blood just from a glass of juice.
I mean, these aren't just historical anomalies, though. These exact pharmacokinetic principles are driving today's biggest medical debates.
Oh, without a doubt. If we connect this to the bigger picture, look at COVID-19 and Paxlovid.
Oh, the antiviral pill.
Yeah. Paxlovid actually contains two drugs. The main one is the antiviral, but the second one is ritonavir, which actually has absolutely zero antiviral effect.
Wait, really? None?
None. It is included purely as a pharmacokinetic booster.
Oh, so it's doing what the grapefruit juice did.
Precisely. Ritonavir inhibits the CYP3A4 enzyme, so the actual antiviral drug isn't instantly broken down by the liver. It buys the drug time to fight the virus.
That is brilliant engineering.
It really is.
And we also see these PK profiles dictate totally different risks in the opioid crisis, like comparing fentanyl and methadone.
All right, they act completely differently based on their kinetics. Fentanyl has a very fast onset. It's highly potent, but short-acting.
So the overdose risk is immediate.
Immediate respiratory depression, yes. Methadone, on the other hand, has a very slow onset and an unpredictable, super long half-life.
Which creates a terrifying trap, because someone might take it, feel nothing, take more, and then it all catches up to them days later.
Exactly. It accumulates, which actually brings up a huge misconception about half-lives.
Right, the idea that one half-life means the drug is just gone.
People assume if a drug have a half-life of 10 hours, in 10 hours it's mostly gone. But mathematically, it actually takes 4 to 5 half-lives to reach 94 to 97% elimination.
So it lingers way longer than people think.
Far longer.
But on the flip side, another misconception is that fast clearance is automatically safer. Like, just get it out of the system quick.
Yeah, that's a dangerous assumption too. Fast clearance means you get these huge swings in the blood peaks and troughs. The level shoots way up, then crashes way down.
And that swinging is dangerous.
Very. Especially for drugs with a narrow therapeutic index, where the toxic dose is uncomfortably close to the effective dose.
Right. And that's where therapeutic drug monitoring, or TDM, comes in, right? Actually drawing blood to check the levels.
Yes. For a drug like lithium, TDM is essential. You have to draw blood to know they are safe.
But it's debated for other drugs, right?
Heavily debated.
Yeah.
Because constant blood draws are stressful for the patient, they cost money, and if the drug has a wider safety margin, we argue over whether that monitoring is actually worth it.
So what does this all mean? When you step back and look at ADME, pharmacokinetics is really this quiet mathematics protecting us. Like every time a nurse adjusts a dose for a kidney patient or warns a pregnant mother about what to take.
Absolutely. It is the invisible architecture of pharmacology.
It just transforms a simple pill into this insanely complex journey of absorption, distribution, metabolism, and excretion.
And, looking forward, it leaves us with a really fascinating thought to ponder.
Oh, what's that?
Well, earlier we mentioned how pharma companies use in silico PBPK modeling, right? using computer simulations of organs.
Right, testing it on a digital human.
And we also talked about pharmacogenomics, how your specific genetic profile drastically alters your personal ADME.
Like the ultra-rapid codeine metabolizer.
Exactly.
Yeah.
So if you put those two together,
Mm.
how far are we from a future where a doctor doesn't just write a prescription, but instead they run a simulation of your specific genetic digital twin?
Whoa!
Right. To see exactly how your unique liver enzymes in your exact kidneys will fight a drug entirely on a computer before you ever actually swallow the pill.
Running the mathematical war digitally before the real battle even begins, that is incredible to think about. Well, thank you for taking this deep dive into the hidden machinery of the human body with us. Keep questioning, keep learning, and we will catch you on the next deep dive.